Thanks everybody for coming. Thank you to Bristol Myers Squibb for sponsoring today. My name is Carly Lodowicz. I'm one of the cardiac surgeons here. It's my pleasure to welcome Dr. Rakesh Arora as this morning's Grand Round speaker. Dr. Arora is originally from London, Ontario in Canada. He attended the University of Toronto Medical School before moving to Dalhousie University in Halifax, Nova Scotia to complete his cardiac surgery residency. During his residency, he also completed a PhD in neurocardiology. And then after completing 2 further years of training at the University of Calgary, he became the first cardiac surgeon in Canada to do a fellowship in critical care medicine, as well as cardiac surgery in 2006. He joined the Cardiac Sciences program and section of critical care medicine at the University of Manitoba as an academic clinician scientist in 2006. He was appointed the Director of Research for the section of cardiac surgery in 2007 and promoted to full professor in surgery, anesthesia, and physiology and pathophysiology at the University of Manitoba in 2016. In 2017, he was appointed to section head of cardiac surgery, and I was fortunate to work closely with him for nearly 10 years during my medical training at the University of Manitoba. He was not only one of my clinical supervisors, but also a research mentor and co-advisor during my master's degree. Dr. Arora has established himself as a leader in the perioperative care of the cardiac surgery patient. In 2009, he pioneered a national society, the Canadian Cardiovascular Critical Care Society, or CanCare, that aims to advance the care of critically ill cardiovascular patients using interdisciplinary expertise in a cooperative model. In addition, he is a past president of the American Delirium Society and a co-founder of the International Federation of Delirium Societies, iDelirium. More recently, he was appointed to the executive of the Advanced Recovery After Cardiac Surgery Society, ERAS, and as an associate editor for the Journal of Thoracic and Cardiovascular Surgery, chair Society of Thoracic Surgeons Workforce for Critical Care, and president of the Canadian Society of Cardiac Surgeons in 2020. In 2022, Dr. Arora migrated south of the border to join the Division of Cardiac Surgery and the Harrington Heart Vascular Institute as the Director of Perioperative and Cardiac Critical Care. He is a clinical professor at Case Western Reserve University and also the Director of Clinical Research of the Division of Cardiac Surgery. His personal research interests have concentrated on enhancing recovery and care of the critically ill cardiac patient. He has specific focus on delirium and frailty in the older adult undergoing cardiac surgery, and he has received funding from the CIHR, HSFC, and the Canadian Frailty Network. Dr. Arora has over 250 peer-reviewed manuscripts and book chapters and is an internationally invited speaker for his team's clinical and research endeavors. It's my pleasure to introduce Dr. Arora today, who joins us to speak about ERAS for cardiac surgery. What's all the hype?
Thanks so much, Carly. I said keep the introduction short, but thank you very much for the opportunity. It's really quite an honor and privilege to be here tonight, this morning to talk to you. I had a really fantastic evening with many of your team members last night over dinner where we got into the weeds and a couple of things, which was great to get started. That'll hopefully address some of that in this talk today. These are my disclosures. I'll talk a little bit about nutrition, but not any specific products. It doesn't have any direct interaction with this talk. I'll also disclose that while I'm an enthusiast for older adults, I'm not a proper expert. I have a lot of proper experts that I've worked with over the years. Hashtag geriatricians are cool. If you don't have a geriatrician that you interact with regularly, please find one because they're immensely helpful to our patients in terms of how we can do better, whether looking at it in a different perspective than perhaps as surgeons or intensivists. Also, it's a great privilege to be here with Carly. She was really, we got to be part of her journey over the past decade. As she mentioned, it's been a huge pleasure to see how she's raised to the ranks and now has her first gig here. And you're very lucky to have her as part of your team. So congratulations to you for hiring an outstanding individual and a real privilege to be here as an invited speaker. Okay, knowing it's the morning and people have to go off to rounds and surgery and so forth, I'll start with the most important slide. And if you take nothing else away from this talk, this is probably a pretty good start. So there's 3 things that I wanted to kind of drive home by the end of this discussion we'll have this morning. One, when you talk about quality in the cardiac surgery patient, we're really talking about improving their recovery. Once they have had their surgery, you've done our job, and then now we're really trying to get them healing from the surgical incisions and the trauma that comes with that. And linking quality ERAS are sort of like peanut butter and chocolate being mixed together. ERAS in cardiac surgery is something we have to look at through the entire patient journey, so starting with the preoperative phase and being more comprehensive in how we evaluate risk, because patients are getting older and sicker, and I'll elaborate a bit more on that. And it really is an interdisciplinary team sport. All members of the team have to understand where you're rowing the boat and how you're going to get there. And this is sort of the reason why. This is the three-strike paradigm that Jim Rudolph, who's a geriatrician at Brown University, and I came up with a few years ago, where we talk about why our patients can get into trouble. As we've talked about, some patients are getting older and sicker, and I think we've been lamenting that for the past 2 decades, but now it's really in our backyard with the mean age of the baby boomers being well over 65 now. This is now a problem we're dealing with on a regular basis. With that comes some baseline vulnerability. There's some cognitive difficulties on top of their atherosclerotic burden or valvular disease they have. There'll be some frailty or nutrition issues, and psychosocial stressors, particularly been realized after COVID, where social isolation and lack of interaction can augment that vulnerability. They undergo the stressor of the procedure itself, whatever that looks like, minimally or maximally invasive. There's the anesthetic, the blood loss, transfusions, and fluid shifts that occur. The things that we do the patient then in the post-operative phase, hemodynamic perturbations, sleep deprivation, pain modification with opioids and others, that it can add insult to injury, or the third strike to this paradigm, and that can lead to poor outcomes like delirium or other negative outcomes after surgery. So when you think about enhancing recovery, I think where we need to go from this term of enhancing is really expected recovery for our patients, and I'll kind of emphasize that a little bit as we get towards the back end of this talk, but really looking at the entire patient journey from when they come in prior to the door coming in for surgery and how they look upon discharge. So trying to save both in-hospital length of stay, ICU bounce backs of recidivism, and hospital readmissions, which are important both from a patient-centered standpoint, but also from a healthcare system standpoint. So again, this is an old ad which belays my age a little bit. This is a Super Bowl ad from the late, early 80s, where you have to think about two things always being put together. That they seem separate, but when you mix them together, you get a better result as an end. And I don't know why this lady's walking with an open tin of peanut butter eating with her hands in public, but that's a separate conversation, perhaps another day. Okay, so again, patients are getting older and sicker, and as I'm a bit focused on frailty, the eyeball test we may do, we look, you look fit enough, off you go for surgery, is probably not sufficient anymore in the current age, and we need a more comprehensive plan. I'll talk a little bit as that goes on. And there's nothing worse than doing a perfect operation and having a complication happen afterwards. So we really need to win not just the battle, but the whole war, as it were, with these older adults to ensure that we have success. And so the way we've thought looking at this now in the cardiac surgery world, at least through the Society of Thoracic Surgery, is looking at how we can reduce failure to rescue. So failure to rescue is this new metric being promoted that's likely to start coming through our database in terms of reporting, where you have a mortality that occurs secondary to a potentially preventable problem. So the major risks that occur, major morbidity elements of the STS score being new renal failure, re-exploration for bleeding, stroke, MI, et cetera, are all now being incorporated into a score called failure to rescue. The reason why that's important, it takes away the individual reporting for a surgeon and looks at your healthcare system as a whole. So how you respond to a complication to prevent a mortality really takes a temperature how you're doing as a group, and that's the intention behind it. So that's coming for us. So how do you break down where that failure to rescue is attributed to? So this goes to really important work by a few collaboratives here in the US, the first one being in Michigan with their quality collaborative led by Richard Prager, where they talked about phase of care mortality analysis. It's been replicated by the Virginia group and the Maryland groups as well. And when you look at the reasons for why patients die after an operation, while we attribute a lot of that mortality to the surgeon, only about 15 to 20% actually occurs in the operating room. It's actually quite rare. And you look at then the reasons for why people do succumb after surgery, it's either due to lack of evaluation, appropriate consultation, or optimization in the preoperative phase, and probably about 2/3 of it in the postoperative phase, of which about 30% or so can be attributed to the ICU. And the top two categories where this occurs, either due to a catastrophe that occurs that was probably unanticipated, or those where you have a failure to pattern recognition for a patient who had an acute decompensation, therefore a trajectory led them to a mortality. And when you go through this process and try to find the root cause analysis of their mortality, again, a lot of this can happen in the preoperative phase and also in the postoperative phase based on processes of care. So to frame this a little bit, let me give you a case example. This is an amalgamation of a couple different cases, so to make it seem, to combine all these concepts together. So you've got a 73-year-old male who was initially referred for a colorectal procedure. And during his workup by the anesthesiologist, they noted a murmur sent for an ultrasound, has a critical AS, had a cath, and had subsequent 3-vessel coronary artery disease that was identified during that workup. So a deviation from the initial surgical plan for his oncologic procedure came through your office for a cardiac surgery evaluation. And when he's there and he's talking to your clinic nurse outside, she's asking why he's there, and he seemed a little befuddled, and he goes, I don't know, I think I'm here for something for my heart, and really wasn't sure why he was there for this particular event. So in Canada, we use the ERAS score. So you do your surgical evaluation, you go through your risk of what this patient's going to have, and overall he's deemed to be a low risk with what seems to be a straightforward AVR CABG with a predicted mortality of less than 3%. He goes through a surgical procedure and wakes up wildly agitated and thrashing about and self-extubates himself upon arrival to your ICU. And so the team tries to get control of the situation, gives him some lorazepam, then some hydromorphone, then some more tramadol, and then some haloperidol. Now you no longer have an agitated patient. You've got a sleepy patient who then becomes very hypoxic. So this poor fellow now is aspirated, and now he's got a new problem where he has to be reintubated and has a very long road of recovery there afterwards. He gets extubated and reintubated a couple times, eventually gets a tracheostomy, gets to predictable ventilator-associated pneumonia, has a acute kidney injury, and has a long day in hospital and gets discharged to somewhere other than home afterwards. So while this may not count as a mortality, when you look at that failure to rescue metric, it's probably a failure to rescue in terms of a good outcome. A person who had a low-risk procedure by our usual assessment, who had a very unwinning-like course post-procedure. So then the question is, if your patient leaves the hospital, is that good enough? And by our metrics, it kind of is. I guess they meet the 30-day mark, but it's probably not successful from a patient-centered perspective. So when we looked at this a few years ago, we made up a term. We published it 4 times, so it counts as a real word, but it's not really a term. But functional survival, so patients who survive and go to their own home is deemed as a good functional survival. Someone who either dies or has to be discharged somewhere other than home, so a SNF, an LTAC, or a long-term care facility, be an example of someone with poor functional survival, because that's not what they came in for. They came in for a procedure, and this dude initially wanted to have a colorectal procedure, and now has had his oncologic surgery also delayed some period of time as well. So that's an example of how it wasn't great. So during this gentleman's agitation, he grabbed a pair of scissors off the bedside table and stabbed one of our nurses with it. I have a more dramatic example from my current institution I can talk about a bit later on. But he wrote this letter of apology sometime thereafterwards when he had recovered, which I thought was remarkable in of itself, and 2, that he was thoroughly ashamed of his behavior. So we thought as a team we had to look at this problem very differently. We had to do a better job in protecting these patients. So it came down to one of our nurses saying, this is not acceptable. We have to find a way to evaluate patients' risk before the operation better, and then be prepared for these patients when they have anticipated difficulties afterwards. So one of the key things that I learned from our geriatrician friends is that a number of our patients can be deemed frail. And if you're frail, you have a much increased rate of delirium and other negative complications after surgery, major adverse cardiac and cerebrovascular events. And frailty is really this umbrella term that we use that really incorporates all the things you see there under the umbrella in the top left corner, such as weakness and sarcopenia, slow gait, and speed that you probably heard about in our world for a little while. But from a geriatrician's perspective, it's more than just a physical component. It's also the psychological component where they may have cognitive difficulties, mental health illnesses, or there's lack of social constructs, so social isolation, substance misuse disorders, and so forth. And when you combine all of those things together, it's quite prevalent in our patients and leads to higher rates of negative outcomes. And there's been some data looking at this again, going back to that failure to rescue metric, where higher rates of frailty are associated with higher rates of failure to rescue. So again, how your system and team prepare for surgery contribute to negative outcomes afterwards. So how do you deal with this? So there have been a number of different theories or thoughts of how we can manage these patients in terms of better communication, having teams to respond to patients who may not be doing well on the floor quicker, using EMR or leveraging that technology for smart alerts. But another way they've looked at it is developing pathways that really identify risk and seek to optimize those patients during the entire patient journey, or ERAS pathways, or enhancing recovery pathways. So there have been a number of these done for the various surgical specialties over the past 20, 25 years, starting in the early 2000s with orthopedics and colorectal surgery. We in the cardiac surgery game have been a little bit late to the game, we'll say, with the first group interaction being in 2018. We put out our first guidelines in 2019, and we're just in the process of doing a version 2.0 that should be out later this year. And again, very similar to the other ERAS groups, we're looking to find a way of providing better care through the entire journey using the interdisciplinary model. So this is sort of our initial executive board and advisory board, and we have a number of subject matter experts internationally that help contribute to our guidelines. This is our first go at it in 2019. We put in JAMA surgery, and it really breaks up all the features that we're meant to seek to optimize in the preoperative phase, intraoperative phase, and postoperative phase. And there's some of this you're doing already, but when you look at this long list of 22 steps, it can be a bit overwhelming. And similarly, when you look at how you can rescue patients after surgery, they comment a number of these features that we've talked about already. And so if you're not doing all this already, they're kind of suggesting you should. And that seems to be somewhat impossible for most of us mere mortals. How do you start this in your system? And I'll talk a little about that as you go on. But really, the principle behind this is it's greater than the individual components. It's the sum of the parts, or improvements through the theories of aggregate marginal gain. So a little bit of changing of a lot of things can lead to big improvements to your patient's care. So talking a little bit about where enhancing recovery came from. Most of us are familiar with fast-track anesthesiology and getting patients extubated in the first 4 to 6 hours after their operation. And you think about the original fast-track papers, it's always kind of fun to dive a little deep into the antiquities of what we do. It really goes back to the mid-1800s, where the first anesthetic was given by a dentist who was taking a big tumor out of someone's neck, and now called the ether dome in Boston. And they didn't know if it'd work or not. They thought just try it. And rather than the patient writhing around while they're extracting this big tumor, he seemed to be relatively calm. They could do the procedure without a lot of bleeding. The patient walked out of hospital. We've now moved on to early extubation in the last 3.5 decades or so for cardiac surgery. I Googled super fast and this picture came up. It has nothing to do with this talk, but it made me laugh, so I included it. And so where our goals have been for the metric from the STS to be extubated within 24 hours, which seems far too long for most of our patients, fast track has really been about 12 or 6 hours ideally, or even shorter. More recently, and in the last 2 years of the double ATS and STS, there have been a number of papers presented about OR extubation or ultra fast track. And that's, again, a conversation we can get into and the necessity of that. We did look at this to see if we made a difference in our outcomes at our previous institution, had a long history of doing this, of OR extubation. This is our resident who's just finishing this year, Ricky Muller-Moran, who looked at our data, where we had a OR extubation rate as high as 60% at certain parts of our history, with high rates of safety, low rates of reintubation, and low rates of re-exploration, though that's not been the experience everywhere. But again, speaks to the issue that if you're going to do these sort of ultra fast track or enhanced recovery protocols, you have to do it the change or the speed of your team's able to compensate. So if you have a team that's ready to do these types of things, great, but this is probably not where you're going to start with enhancing recovery for your particular group. So where do you start then? So while we focus a lot on the post-operative phase, I'm going to shift our attention a little bit towards the pre-operative phase, where I've spent some time looking at over the past few years. So frailty, again, is common in our patients. If you look for it using any one of a number of systematic tools, about 50% of your patients will be frail. So how do you look for that in your patient? What you're really looking for are those patients who are really aged well versus those who haven't aged well. And where we've used the eyeball test in the past may have been adequate. In more recent years, I suggest it's probably not as good. And this comes down to the fallacy of that particular assessment. So I'll use a car by way of analogy to illustrate this point a little bit. If you have a car that looks like this, it's not going to do very well in a road race. And if your patient comes in that's missing a limb in a wheelchair, that's pretty obvious that patient's not going to do well with the stress of surgery. Most cars don't look like that. They're maybe slightly older vintage, slightly different color, slightly different shape. From the outside, the car looks like a car. However, if you look at the fuel gauge of that car on the inside, if one has a full tank of gas and one's nearly empty, obviously one's going to be better in that road race than the other. And the eyeball test doesn't tell you the fuel gauge. So we need to dive a little deeper to understand how frail or how much reserve your patient may have for the stress of surgery. And so when we looked at this again in our patients and others over the past few years, this diagram sort of illustrates the problem a little bit. So imagine you have two patients, one's indicated by that green trajectory, the other one by that red trajectory. And the dotted line will say is the functional capacity threshold. When you're below that level, if you were not to recover, those are the kind of patients that don't do well and go to a SNF or an LTAC after an operation. So what you want to do is identify where that starting point is of the patient, because once they have the stress of an illness. In this case, we're showing you a urinary tract infection, but it could be cardiac surgery or a TAVR or any other type of stress to the system. You have a predictable drop in function, and then you have a recovery. That recovery or resilience is sort of the yin to the yang of frailty, indicates how quickly they bounce back. The patient starting at a lower standpoint has a much deeper drop in their functional capacity, a much longer time to recovery, and just kind of sneak above that functional capacity threshold, but they still may ride that back and forth and may or may not get to their home status. So the top one would be someone with an appropriate compensation. We want to identify those patients who have decompensation and higher adverse events or mortality. And again, if you have that second case, you have much higher rates of negative outcomes. So how do you look for it? There's actually a task force started now by the STS where we're going to provide formal recommendations to our society of what frailty tests we should be using in the preoperative phase. This is one from Jonathan Affolala, who's a geriatric cardiologist, which is a really unique term that he created, but I think it's really smart. He's in Montreal, and this is from the Frailty AVR study, where it was a multi-center trial looking at a battery of frailty assessments, and then we picked the best ones of those we thought were most implementable in a clinical setting, and really involves some measurement of muscle strength, so a chair to rise test, a brief assessment of cognition, and some basic blood work such as a hemoglobin and serum albumin to get an idea of their starting point of anemia and nutrition. To help teams, Jonathan started an app. It's available both in Android and iOS. I don't have any financial interest in this, and I believe it's a free download as well. And how this works, when you plug this in, you get you put the patient's data in terms of age, what kind of procedure they're having, et cetera. It has a 3-word recall built into this, and so you can have them test that and come back and test them again a little while later on. It has a little timer for the chair to rise test you can use in your clinic, and it gives you a score. And if you have a score above 3, that's a patient that's higher risk, and you may want to have a more comprehensive exam of that patient of how you can optimize them with your geriatricians or other support team members you may have. So it's a simple way to do that. We're deciding whether that's one we want to suggest as the routine or there are other ones, and so stay tuned. That should be coming out hopefully in the next 12 months, what we're going to do. So if you identify someone who is frail, what do you do about it? Well, again, it's a multi-system, multi-focus problem. So this came up with this idea of new prehab where we're talking about providing the appropriate treatment for sarcopenia, so some sort of exercise program, appropriate nutrition to build up muscle stores, particularly due to the protein loss the patient gets around the time of surgery and healing that's required, and also dealing with the cognition or mental health issues they may have in the preoperative phase. Ron Salinger, who's a surgeon in Maryland, changed this a little bit called now prehab, where we're really optimizing a lot of factors in addition to the exercise in terms of glycemic control, smoking cessation, and substance disuse over there, in addition to nutrition and worry. Now, I'll talk a little bit about this. So when you talk about prehab from the ERAS standpoint, there isn't a lot of really good data for us in cardiac surgery, so we have to extrapolate a lot of this from the non-cardiac surgery literature. And it's unclear whether we should delay surgery or not to optimize someone, though it seems like a good idea in a lot of patients. We have a randomized trial we're trying to finish now in Canada that was incredibly difficult to recruit, so we're trying Plan B with a different therapy that will hopefully work, but through various meta-analyses and so forth, doing some sort of picture of prehab in the preoperative phase is great. Now, how do you do any of this? And so that's where I want to focus the conversation a little bit in the last 15, 20 minutes, and I'm really interested in questions and discussions of how this may or may not suit your particular clinical context. So in my new gig I started this past year, we were told we had a length of stay problem. Or I was told we had a length of stay problem about a month after we got there. They said, go fix it. I said, I don't know how to do that yet. So they gave me a team, and I had 3 months to develop a plan that was comprehensive to develop an overall approach of how we're going to reduce length of stay. So we took this as an opportunity to really put an overlay of ERAS within our group, which really wasn't very comprehensive before. And so we looked at this in terms of what we could do now. So a phase 1 early implementation, which we thought was a good way for us to start. And this may or may not reflect your situation here. I'm very happy to talk more about that. And looking at the preoperative phase, intraoperative, postoperative, and how we'd get patients out of hospital quicker, but also safer, so there isn't the hospital readmission rates. So starting with 1, when it came to ERAS, what we had before, while there was a pretty comprehensive ERAS program for 13 of the service lines we had in the Department of Surgery at university hospitals, cardiac surgery was a lower user of that. primarily because you had to opt in. You had to check a box in your booking form that would initiate a process that patients go through that system. So just turn that on its head. We said, well, why isn't every patient an ERAS patient? So this became a default check we did in everyone's chart when they first came through the clinic as an outpatient, and they get then a certain kit. So once that box was checked, it sent out this prehab kit to the patient's homes. So you got a preoperative nutrition kit, which is this Abbott product here. Again, I don't have any particular interest in Abbott, but that's the one we use. It has a higher level of protein to help give them that protein load. You only need about 7 to 10 days of that to probably to have impact. And then the preoperative complex carbohydrate load. So take 100 grams of this maltodextrin carbohydrate the night before, and then 50 grams on the way to the hospital in the morning. And where that seems antithetical to a patient who's probably got diabetes and going to have a transesophageal echo, us and others have shown that it's safe to do. They don't have higher rates of aspiration and actually have better glycemic control postoperatively. In addition to that, they get a little instruction book of what to do with an incentive spirometer and these little exercise bands to do some basic exercise at home. All of this is unmonitored, and we don't know how well they're doing it, but we thought this was a reasonable way for us to start to do something in the preoperative phase that we weren't doing at all. So focusing on the nutrition a little bit, why is nutrition important for patients? Well, again, much like ERAS and surgery, frailty and malnutrition kind of go together pretty frequently as well. So if you look for malnutrition in our patients, about 20% will be undernourished coming in for surgery, and it's not the usual really thin cachectic patient. It's usually an unintentional micronutrient loss in their diet over a period of time. So again, where we focus on nutrition increasingly is starting it earlier postoperatively. We're trying to move this upstream to preoperative as well. So one of the recommendations we had, as I mentioned, is doing the carbohydrate load preoperatively. This has been done in non-cardiac surgery for quite some time. And again, while it seems to be antithetical for a patient with diabetes, it actually improves your insulin resistance. You have quicker time for return of gut function. They start eating quicker and therefore mobilizing quicker postoperatively. So that became sort of a large class 1 recommendation or class 2 recommendation for us with the ERAS, and we're working on better data for part 2. For the preoperative nutrition, again, there's not great data in cardiac surgery as of yet, so we have to extrapolate from other surgical disciplines. But it would seem anywhere from 7 to 10 days of nutrition is enough. You don't have to give a month-long of nutrition, even if they're relatively malnourished. Giving this protein load up front, where you're getting 1.5 to 2 grams per kilogram per day, seems to be impactful. At Duke, where Carly is trained most recently, Paul Wishmeyer, as part of the cardiac anesthesia critical care group, has really promoted this through something called the POET pathway, which is a much more comprehensive supplementation of vitamins and nutraceuticals and so forth. I don't know that you need to do this. It seems very expensive with not a lot of great data in cardiac surgery. So we started with a very low techie type solution. So the next problem we had was, how do you get people to do this? So we had to go through a comprehensive education pathway for all our min clerks, our residents, and the surgeons, and then in the operating theater as well for the anesthesiologists to know why we were doing this as an ERAS pathway, where the focus had been on extubation and using non-opioid medications is deemed as what an ERAS pathway was. We had to really explain it's a much more comprehensive package. So with that small change, in a month, we just started this a month and a half ago, we have had a significant increase in the number of patients who are now put in an ERAS pathway, and we're already starting to see some changes on length of stay on the back end. With it as well, as we talked about at dinner last night, we're going through the joy of converting from Allscripts to Epic, so we have to redo all our order sets. So we've now taken that opportunity to put ERAS into all of our order sets and having a very clear pathway for our team in the post-operative phase. This is very small, somewhat intentionally, because it's really kind of boring to look through all these things, but it's really breaking down the care of the patient from the first 15 minutes, 15 to 2 hours, 2 to 8 hours, what we do in post-op day 1, 2, 3, 4, till they go home. So providing a very clear roadmap of what the expectations are for those patients, not only in terms of getting them extubated, but getting them out of bed into a chair, starting nutrition and mobilization using different pathways. To further help our teams learn how to do this and incorporate this new order set, we had this session at the AATS this past week where we developed a number of turnkey order sets. So one example will be, I'll talk about, it's for acute kidney injury. And what we're trying to do for this is provide a really easy means to take our guidelines and implement it, because guidelines are challenging to know how you actually do this in real life. So we use a number of subject matter experts, went through a Delphi-like process, accumulated the best literature through all our guidelines from our societies, from AHA to the Society of Thoracic Surgery, and developed these sort of order sets. So one would be for kidneys. This shows it in terms of different phases of care in the preoperative phase, intraoperative, and postoperative, of how you do a preoperative assessment to identify risk, what you would do in the intraoperative phase, and how we can monitor these patients postoperatively. Those ones that are sort of in the darker blue and bold print are ones that are really class 1 recommendations from one society we thought was of value. Those in the lighter blue and italicized font are those that are probably 2B recommendations we thought that was low risk but high yield. So what we did, we created this little QR code for all of our order sets. If you want to scan that, I'll leave that up there for a moment. And it has about 5 or 6 different ones for opioid reduction, patient blood management, and AFib prophylaxis, and AKI. So we spent about 6 months putting this together. These will all be published in JTCVS later this year at some point. So if you do all this work, then you want to know that it actually works, so you have to then look at your data. And so one of the problems we have is we're a relatively data poor environment. We're hoping through EPIC that we'll be able to abstract data better, but we wanted to do some basic audits, so we're doing a manual chart abstraction, which is very laborious. But what we think we need to monitor are these core elements for an ERAS program. So this was, again, a consensus we came up with a couple of years ago of the key metrics for evaluation of success of an ERAS program, again, divided into the preoperative phase, intraoperative, and postoperative phase. Judson Williams and Gina McConnell, who I think are really the pioneers of this for our field from Wake Medical in Raleigh, have found a way to abstract data from EPIC, and so you can just steal their order sets and how they do it to have metrics built into how you do work on a regular basis. Judson and his group did the first paper, about 900 patients, in 2019, and found significant improvements with a comprehensive ERAS program that involved all 22 of those steps in terms of length of stay, decreased opioid reduction, improved GI function, better glycemic control, and importantly, improved patient satisfaction. Patients really seem to like this a lot. Most of us are mere mortals and we can't do what Gina and Judson's have done, so we've tried to do this a little differently at UH, and I'll give Greg Rushing and Basanta Mahaptra, who are the 2 leaders in this before I got there a few months ago, and did a limited pilot study looking at elements of ERAS within a group using a mobile health app to track outcomes as an outpatient. And with that, again, the top thing is a bit small, but you're welcome to read through it. It's really the bold print stuff at the bottom that what we found impactful with a very short, we'll say about 8 and 9 month sort of run-in with about 60-some patients, where we found we had a significant reduction in rehospitalization and ED visits postoperatively, less nursing home disposition, so improved functional survival, and less phone calls. So this is early stages, but even starting any element of an ERAS program is probably better than doing none of it, and it can have significant impacts that are realizable in a very short order. So what about the surgical approach? You say, well, I do a lot of minimally invasive surgery. That doesn't really apply to me because that's what minimally invasive is. If you have an ERAS overlabel, the preoperative optimization and the postoperative care, it actually improves outcomes as well. There's a decreased length of stay, less blood loss, and therefore blood product utilization, improved mobility, and improved patient satisfaction. So even in a minimally invasive procedure type, having an ERAS overlay does make significant differences. The next phase is going on to Carly's world, where we're looking at the heart failure patient. So we have had a seminar or webinar a couple weeks ago or a month ago now, and we're looking to do this as a session at EX in the fall about doing preemptive MCS therapies for those people who have heart failure and are deconditioned, and how can we be more proactive in the heart failure patient to provide enhancing recovery pathways to get them optimized for surgery, improve their nutrition, and improve mobility postoperatively. One of the approaches we took in my previous institution, which was somewhat resource strapped, is trying to prioritize which of those 22 steps that we wanted to use. And so I had the good fortune of meeting Dr. Anna Hudik, who's our postdoctoral fellow in patient engagement protocols. And I'll start at the outset that our first meeting with her was saying, I really don't like doctors. I don't know what you guys do, but you do everything wrong. I said, great, we're working together. So that's where this started. So we went through a series of patient engagement panels to understand what was of value to the patient and prioritize those 22 steps based on what they wanted to see first, And so it was around better pain, less post-op nausea and vomiting, better nutrition, and they were really worried about delirium. I said, great, we'll start with that. So that's how we focused our teams initially, by starting with those 4 elements and kind of increase them out over time. And so when you looked at this, while we think we know what patients want when developing all these pathways, it's probably not exactly what they want as a starting point. So this diagram really just kind of shows the overlap. While there were some elements we thought were really important, they weren't as important to the patient. So again, we try to refocus our efforts to be more directed towards the patient and the caregivers as well, in terms of how they would have to manage these patients when they went home as part of our starting point. Okay, I was told to leave enough time for questions at the end, so I'll stop there. And so when you talk about this pathway of enhancing recovery, it can be pretty daunting if you're not doing any of this, and certainly that was the case for us. We had done some of these elements very well, and you're probably doing some of these elements very well in your team at present. So maybe just refining some of those things. Some of this may be new information or new processes you have to implement. And it's really an opportunity for your teams to kind of work together. And I think the joy for me in my new gig has been that I've got to meet a lot of people who I would not have met as quickly as I had to, and start working with them and developing these bonds and relationships that were really patient-focused. And it really got people motivated to move in that direction pretty quickly. So where it may be a difficulty, see it as an opportunity to engage your team and develop novel ways to help your patients and hopefully improve, if nothing else, patient satisfaction, but other metrics that are important for us, such as length of stay and overall costs. So with that, I'll stop, and thank you very much for the opportunity again to talk at you for the last 40 minutes, and I'm happy to take questions from there.
Thank you, Rakesh. So anybody has questions, please speak up.
Hi. This is tremendous. Thank you. One of the things, anytime you have some sort of quality initiative or change in a program, there's always resistance.
Yes.
What have been the biggest obstacles, or what have been the biggest concerns that other teammates have had that you've had to overcome?
Yeah, so the question for those who are listening online, the question is, what were the biggest pitfalls and barriers to moving a team forward who may not have been involved or may not want to do this at all? That's a great question. I'd say that's a constant learning process for me, because I'm still learning how to do this. But really comes down to doing a lot of listening. And if you've ever read the book, Your First 90 Days, it's a leadership book, and how you really have to go in and meet as many people as possible and do a lot of active listening, and then finding out what their desires are at the starting point. That's where I started this gig in Cleveland a few months ago. And it became very clear they had certain things they were really interested in doing first. And they really wanted to work in the preoperative phase, which worked out just serendipitously very well, because that's what I have a particular passion with. But it comes down to finding the team members what they want, and then in reverse, we figured out what patients want. And then if you tell most teams this is what the patients really want, it was pretty easy, at least in my experience so far, to get people to rally around that. Because it's no longer about you or me, it's about, well, that's what they want, we should do what they want. They're really the ones who are taken care of. So if you can keep it patient-centered, and then start small is the other thing. If you start with something very complex, it becomes very frustrating early, so you want to pick the lower hanging fruit that early wins, and it may be something you're doing already that you just need to tweak or refine. So if you're really good at ultra fast track or fast track patients, find ways to now do the next phase of that, get them out of bed into chair earlier. Start with a new movement protocol called Move in the Tube, so you have people moving quicker post-operatively. Or maybe talk about opioids, working with your anesthesiology colleagues to figure out how you can use less opioids and tracking that. So I think it's starting with those small wins and using what you hear as the touch points that the team wants to start with.
Rakesh, I think starting any new initiative is the resources you need. How did you justify these resources? At Case Western, of course, they had a longer length of stay, so they wanted to reduce that cost saving.
Right.
But I feel that it's the efficiency of this is not just length of stay, but is patient recovery long term.
Yes.
So how do you convince?
Yes, that's a great question. So I have some extra slides here I just want to go through. I've stolen from Mark Gerdish. I don't know if you know Mark. He's in the Franciscan healthcare system in Indianapolis, who is in a private healthcare system. So his motivations were very different than ours, but he was looking at what he thought was best for his patients, and he's really bought into this concept. So his major focus was, of everything else, I want to get patients out moving, because he's a a minimally invasive enthusiast and wanted to have patients have the shortest stay possible. To be fair, a little bit of bravado and bragging rights probably, but that was his motivation, and he had a fair degree of control over his team to make this work. So we really centered the whole team around this early mobilization pathway. So they started initially with involving their anesthesiologists by doing a lot of blocks, which you're probably doing here with your group as well. In my experience, 60% of the time, that works 100% of the time. So there's those that works and those that don't work. So he had to find other ways to go around this. And so what he sold his administration was on the principle that 1 in 10 of our patients are going to go out and have a new opioid problem. This is an issue for us because it leads to increased healthcare utilization and affected our global budget. So he focused it that way. What was the problem that he could sell to a C-suite? So opioid disuse was part of that. So then he went on to developing a very comprehensive sort of pathway of using non-opioid structures, got the team to buy into it, but it was complex. So then he switched, and also there's not really great data on that. So this is a really good analysis by Alex Gregory from the University of Calgary. We looked at all these different multimodal things that we think we want to use in cardiac surgery that's not really informed by great data. But having being in the OR and doing a lot of minimally invasive and cryo procedures, he started using a cryoprobe much more routinely. And again, these are very costly, and it's hard to sell your administration on this. But he was able to show by the use of this and by using rigid sternal fixation devices routinely in all patients, which most of us would be aghast at doing just based on cost, he was able to show a reduction in length of stay after buying from the C-suite to make it work. So this is, for those who aren't familiar, this is through a relatively large thoracotomy, we'll say, where he's injecting a probe that you use for your cryo-maze procedures, putting along the rib space to freeze that nerve in that territory, as well as does one through the chest tube site as well to get better control of pain that way. It doesn't take very long. That's about 5 minutes onto your operation. They do have some numbness in the area, and it basically you kill off the axons, and it kind of regenerates by Wallerian degeneration processes over time. Up to about 10% may have some chronic nerve discomfort, so it's not perfect, but that's the way they've done it. So it lasts about 45 days, and when he looked at his data then, so that's the other part of it, to sell your C-suite, you have to have data to show that it's effective. So looking at what's called morphine milligram equivalents, so you convert all the different opioids we use into one drug type called morphine, and he looked at his morphine usage over time, and specifically the bottom curve shows how his patients were going home with no opioids at time of discharge. So significant reduction, improved mobilization, less bounce backs, less opioid use. So that's how he went full circle with this process, something that would be deemed very expensive. So a picture's worth 1,000 words. So these are 2 patients. One had, we'll say, it was golfing within a week after a surgery. The other dude's a younger guy who is playing baseball, and you're supposed to guess which one had a sternotomy, which one had a median sternotomy. The trick of this one is both had a median sternotomy with rigid sternal fixation. They're back doing their things within a week. So again, these things are very sellable to your C-suite as well if you have patients willing to do this as well. This is an example from Winnipeg. So our anesthesiologists were really big on OR extubation. Carly's laughing at me. I think I've shown this video before. So this is a gentleman who was 78 years old who had a pretty good alcohol disuse, who just immigrated from the Philippines, so didn't speak English, had an acute coronary event, had coronary disease as well as a valve, and had to be have an urgent procedure done in hospital. So about as high risk for post-op delirium as you can imagine. So he gets wheeled into our ICU here. This is he was extubated in the operating room. This is him landing in the ICU. So Doug McGuire, who really embraces philosophy at our previous institution, gave him a newspaper to show off. Well, look, he's reading a newspaper. Look how awake and cognitively aware he is. So if you're astute enough, you realize this paper's in English, and I've already told you he doesn't speak English. So he went one step further, and we gave him an iPad and had him start playing solitaire. So this is a guy who's never seen an iPad before, apparently, and now is playing solitaire. So if you have your team attuned to this concept of getting people through with minimal sedation, minimal opioids as possible, it's achievable.
Yeah, but I've never played solitaire in my life. I don't even know the objective.
So you get the idea. So this is again just showing off what teams can do when you're really attuned to this. And it became to a point where our nurses in the ICU, if someone came out intubated, so well, what's wrong with this patient? Why are they not extubated? So a very different philosophy because they're anticipating people to come out looking like this. If they're not, then they get worried that we have to be more attuned to that patient that may have complications post-operatively. Here's another show-off picture where he's giving someone a popsicle. Again, I wouldn't recommend this, but we had a popsicle fridge as you walk through the units. You grabbed it as he doing the handover in the ICU, gave the patient a popsicle. He seemed very happy that he had it. Okay, so that's sort of my very roundabout answer to your question, that it's none of this is simple. It's complex, but it takes small buy-in and building on those incremental gains over time and getting a culture of change. So Peter Pronovost, who you may know, was at Hopkins, now at University Hospital, is a big quality checklist guy for the ICU world. And he's a quote that I steal all the time. And another one I've gotten from Louis Perot, both of them. Louis Perot, who's a cardiac surgeon at Montreal Heart Institute, his theory is, I know I'm going to win, I just don't know when. And really speaks to dogged persistence on getting change. And then Peter's quote is, change occurs at the speed of trust. And so you got to get that buy-in from your team, particularly if you're the new guy, trying to build those relationships and understanding what they want to do first and moving in that direction and be flexible about it. Yes.
And we talked a little bit about this last night, but when you're building a team of people to try and sort of implement some of these things and develop a program, who do you see as critical players, and how do you try and structure that team because this is really reaching at many different aspects of medicine.
Right. So the question was, for those who are online, was how do you structure a team to be effective? So I'll tell you two different ways. In my previous gig, we found the person who was the biggest naysayer and included them up front, because there's always one or two people in your group that will be the culture killers. And if you can get them involved at the early stage where they feel involved, I found that to be helpful. In my newer group, I was kind of given a team, and I didn't have a choice who I was working with. They said, this is the team you're going to work with. So we had a group of 12, and then narrowed it down to 5. And so that's sort of the Jeff Bezos rule. Start with a committee you can feed with 2 pizzas. Any bigger than that, it's too many people, and there's too many divergent sort of opinions, and people don't get the work done. So starting with a core group of somewhere between 4 and 6 people was really important as well, and trying to find out what their particular interests were. And they were quite divergent. And that's okay, but just use that to your advantage. So none of this, again, is simple, but it's really around a lot of active listening and people management, and then having regular check-ins about progress. We were meeting every 2 weeks over these 3 months to make sure we had progress. And we didn't, we would go help out that particular group, and we divided up in tasks. So there was a preoperative group, there was the intraoperative group, the ward group, which was the toughest one, to be honest with you, and the discharge planning group. So we were able to leverage talents in each of those areas. So our discharge person found a way to negotiate with 5 of our our insurance providers, where in the past when you had someone ready for discharge, that's when you start your process of pre-certification for discharge planning. We took ownership of 5 of those so we could start whenever we wanted. It saved about 1 to 2 days just for that alone. Also through COVID, the hospital had developed this hospital at home process, which a number of centers have done to keep people out of hospital. So they don't have any work to do right now. So I said, well, why don't we use them for us? So patients who require anticoagulation or better rate control or home oxygen, we're discharging people 1 or 2 days earlier now to hospital at home. And the important part for that for us from the hospital standpoint, it counts as a discharge. And if they come back to hospital, it doesn't count as a different institution. So there was ways that from a monetary standpoint, it worked out well for us as well. So it was a lot of sort of learn as I went, to be honest with you, this past little while. And either you get to choose your team or you get a team given to you that you have to work with, and you have to just figure out what their particular interests are and leverage those to the best of your ability. Sir.
Thanks for making Monday morning worthwhile here. I appreciate it. Do you have any thoughts on how to approach the low risk population that don't have frailty and because those are sometimes the worst outcomes that are the most distressing, I guess.
I have that slide in here now. So that's a really good point. And so when you look at the data from the phase of care mortality analysis, another work that the group in Ontario had done, let's say about 13 years ago, the patients at the highest risk of preventable death are the lowest risk group patients. Those with a risk score of 1 to 3% of operative mortality have the highest rates of mortality that's preventable. So while you think those patients are the ones who sail through, they require probably as much attention as those with a low EF who predict a rocky course post-operatively. And so like Mark has done for his rigid fixation group, I don't know which patient's gonna do well and not do well other than what the risk score tells me. So I teach everyone the same. everyone gets the same protocol, whether you're starting with an EF of 15% or 65%. And whether you're frail or not frail, we give you the same nutrition package. Because no matter, however you look at it, you're gonna lose protein after surgery. You probably use about 400% of your protein stores over baseline when you go through surgery for just the stress of surgery, wound healing, et cetera. So any patient can benefit from that. And I think, again, if you extrapolate that from the non-cardiac surgery world, who've been doing this much longer than we have, they treat it the same way as well. Whether you're having a straightforward breast surgery procedure or a full oncologic APR resection for colorectal cancer, everyone kind of gets the same package. So you treat everyone like. You don't differentiate between low and high risk.
Just one more question.
Yes.
So I think, would you advise to start this with, I would say, high-risk group? Like, we can focus on patients who are obese, or patients who are diabetic, or patients who are 80-year-old, and see, who are the main stakeholders who can contribute, and then roll it out in a bigger way. Because, again, I think it may be easier to show the benefit in high-risk group.
Mm-hmm.
Would you think that approach would be?
Yeah, so that's a really interesting question. So the question was, again, for those online, was do you start with a higher risk group or lower risk group? And I've tried doing the higher risk group, and they're really hard to change. So if you take older adults or frail or patients with poor glycemic control, even in Canada where we have socialized medicine, we can give their products for free, they don't want to do it. So I'd almost, and now again, not any day, that's just my opinion, so I'll qualify that based on a little bit of experience. To your point is, how do you treat the low versus high risk patient? If you want to start a process and show success of the process, that you can do it and that patients go through it, I'd almost argue the lower risk patients who are probably intrinsically a bit more motivated to recover, maybe that's the place to start. Because people who have, again, poor glycemic control or smoking or never exercised before when they're 70, to make them now do everything you want them to do is actually pretty challenging, I've learned. So I don't know the answer to your question, but if I had to do everything over again, I'd probably start with the low wins first, get the process started, show that it works, and then build upon the more complex patients, because they'll take more comprehensive care. Like, you need to involve an endocrinologist, you have to involve a geriatrician, you have to involve a nutritionist, which are additive to the complexity of the process. Great. Well, thank you very, very much again for the opportunity to speak to you all day. And Carly, thank you very much for the privilege of being your speaker. So that's great. Thank you.